From Faithful Word Media, this is Healthcare Musings. I'm Dr. Hashem Hasabala. Hashem Hasabala here on Healthcare Musings. I'm so happy to have you with me. And I'm also very happy to have Dr. Vivek Tirmal. He is a colleague, he is a friend. He is the team lead for denial management in Sound Advisory Services, who is my employer. I also am a physician advisor with Sound Advisory Services. And we're going to talk about something that has annoyed me to no end when it comes to insurance payers and their denial techniques and the things that they do. And so we'll get right into it. Dr. Tirmal, so happy to have you. Welcome.
Thank you for having me. It's great to be here.
Absolutely. So just give us a brief kind of intro to you and how you ended up with Sound, and then we'll go right into it.
Definitely. I went through surgical residency, finished a trauma critical care fellowship, and pretty was much burnt out after that. And
Wow.
I eventually went to school to get my MBA in healthcare management, and that led me to working as a administrative medicine fellow at Central State Medical Center in Freehold, New Jersey. And while I was working there, I came under the mentorship of the physician advisor at that hospital. His name is Dr. Howard Stein. He's a leader in our field of medical utilization review. He's one of the first physician advisors that actually, he's a pretty well-known guy in our community. Anyways, from there, I started working for Executive Health Resources, which was bought out by United Health Group and became now Optum Physician Advisory Services. And after that, I worked in Maine at Mercy Medical Center, and from there, eventually worked for Sound. Basically, I've been in this field since 2010. Have a lot of experience. I've pretty much done utilization review with regards to every single type of case that you can imagine that involves the human body, from the toes all the way to the top of your hair. You name it, I've done it. I've argued it. I've appealed it. I've worked all aspects of utilization review as a physician advisor. From actually doing the concurrent inpatient status certifications and reviews, up to appeals denials, to training other people. I've kind of done everything in this field.
That's great. That's exactly why I wanted you on the podcast. Happy to have you, and great that you're with Sound. It's good to have someone with your experience to be a resource, and I definitely use it all the time. So I definitely appreciate you.
Thank you.
So every time I did appeals this morning, actually, before I go to work in the ICU this afternoon, and the payers, they love to do this one line from a page in the coding clinic, the American Hospital Association. I think it's the American Hospital Association coding clinics from 2016. And it's one line from page 148 where they say, an insurance payer can use whatever criteria they want to determine the validity of a diagnosis. And then they go on and say, well, the hyponatremia doesn't exist. In fact, I wrote an appeal on a case, you might be familiar with it, where they denied hyponatremia, even though literally almost every sodium level was below what they said was hyponatremia. Not only that, I averaged it. I actually did the average over the whole hospital stay, and it still came below what they said. And then they still, it went to a level 1 appeal, and that was upheld. The denial was upheld. And then I did the level 2. It's just baffling that they would say, the coding clinics say we can do whatever we want. And then they say hyponatremia, according to us, even though they're not doctors, is less than 135. And almost all of them were less than 135. And if the average was less than 135, how did they get away with this? Where did this come from?
Well, first of all, it's not what they say is the reference range. It's the hospital's reference range. Not all labs have the same reference range. So you have to use what the reference range is for the test that's done, because no two tests are the same. So you have to actually go by the actual testing kit to see. Like if you just do a simple blood sugar measurement, the Freestyle Libre versus Accucheck, we all know what standard accepted blood glucose levels are. 70 to 90 is considered normal, but that's not necessarily what the test is normal for that test. So we have to go by what that test is and what that trending is. Now, you mentioned that as one line. It's actually about half of that sentence, which they take in. So it's a blurb from a specific sentence, which is part of, it's on page 149, but the actual question goes from 147 all the way up to 149. So it's actually 2.5 pages of explanation here. So you can't take a blurb of half a sentence out of a very lengthy explanation here. Let me just read to you the question that generated this response.
Yes, please.
And the question is, please explain the intent of the new ICD-10 CM guideline regarding code assignment and clinical criteria that reads as follows. The assignment of a diagnosis code is based on the provider's diagnostic statement that the condition exists. The provider's statement that the patient has a particular condition is sufficient. Code assignment is not based on clinical criteria used by the provider to establish the diagnosis. Some people are interpreting this to mean that clinical documentation improvement specialists should no longer question diagnostic statements that don't meet clinical criteria. Is this true? So that's the question. So they basically, a coder is asking whether they should be starting to be questioning the clinical validity of a documented diagnosis in the medical record. And are they allowed to do that? Now, mind you, this is from the fourth quarter of 2016 HA coding clinic. So I don't want to be plagiarizing here through the podcast or whatever. I don't know how it works, but I am attributing this to that specific article from HA coding clinic. Now, it's a very lengthy response, which covers 2 pages here. The question was half a page, and the rest of it is like about 2 pages here. Now, let me read to you the relevant sections of this. Now, the answer, the first paragraph of the answer states, coding must be based on provider documentation. This guideline is not a new concept. Although it had not been explicitly included in the official coding guidelines until now, Coding Clinic and official coding guidelines have always stated that code assignment should be based on the provider documentation. As has been repeatedly stated in coding clinics over the years, diagnosing a patient's condition is solely the responsibility of the provider. Only the physician or other qualified healthcare practitioner legally accountable for establishing the patient's diagnosis can diagnose the patient. Now let's just stop here. What did I just say here? Who is responsible for establishing the diagnosis of a patient, of a disease that a patient has in the hospital? It is not the coder, it's not the CDI specialist. It is nobody else other than the treating clinician that is responsible for the care of the patient in the hospital. The person is legally accountable for that person's care. It is not the insurance medical director or whoever is denying it, an insurance company. It is not anybody else other than the treating clinician, whether it's the treating attending physician or the nurse practitioner or the physician, whichever physician extender that might be, that person who is treating that patient and is legally accountable for that person's care, that patient's care, is the person that's responsible for establishing that diagnosis. Nobody else. Coding Clinic is very clear in stating that. Also, it must be stated that the HA Coding Clinic is a guideline for coders for establishing and legislating the rules by which they create codes that eventually go to ultimately result in the billing of the ultimate reimbursement a hospital receives for a patient. Now, anything clinically related is very far outside the scope of HA Coding Clinic. So again, in this case though, they're very clearly stating that the treating clinician is the one who's legally responsible for the care of the patient, is responsible for diagnosing the patient and establishing that diagnosis. Nobody else.
So then where do they come off? Where do they come off?
Well, let me get to the rest of it.
How do they use that then? Where do they come off doing that?
Well,
Because I see it all the time.
I agree with you, but this is just the beginning of a very lengthy explanation, and they're only quoting half a sentence here. So now going on here, I'm just going to skip to the relevant paragraph here. The last paragraph. There's 2 more paragraphs in between. You should go through reference materials and various different, go through other references, but in the last paragraph, it says, while physicians may use a particular clinical definition or set of clinical criteria to establish a diagnosis, the code is based on his/her documentation, not on a particular clinical definition or criteria. In other words, regardless of whether a physician uses the new clinical criteria for sepsis, the old criteria, his personal clinical judgment, or something else to decide a patient has sepsis and document it as such, the code for the sepsis is the same. As long as sepsis is documented, regardless of how the diagnosis was arrived at, the code for sepsis can be assigned. Now, this is very frequent. That reference that you're talking about is very frequently used to deny sepsis.
All the time.
All the time. And they are directly referencing it, sepsis here, saying they don't care which coding guideline or which sepsis guideline is used to diagnose sepsis. All they care about is that the physician, in his or her judgment, found that the patient has sepsis based on their own clinical judgment and acumen, and are treating sepsis and are documenting the diagnosis of sepsis. That's all that counts.
So let me play devil's advocate here. So, okay, that's true. And we do have, and I'm, you and I are both intensivists, right? So we do have evidence-based clinical definition for sepsis 3, where
Correct.
it's very specific about what researchers in our field feel the definition for sepsis is, mainly for randomized clinical trials, and they're all over this, right? Because it's stricter, it's more difficult to arrive at a diagnosis of sepsis with sepsis 3 rather than sepsis 2. So,
Correct.
I mean, that's one thing, and then the other thing is, I mean, I also can't just make things up, right? I mean, I can't code hyponatremia if there is no evidence of hyponatremia, right?
Correct.
So this case, there was clearly evidence of hyponatremia, and they still said it doesn't count, which doesn't make any sense. We're like, you can't hinge it all on, well, whatever the doctor says, because what if it's not there?
Well, the thing is, now we're approaching two different topics here, and we're merging them into one when they're actually two separate topics.
Okay.
One is a coding topic, and the other is a clinical validation topic. What you're discussing is a clinical validation issue. Now, clinical validation is, was the diagnosis actually there or not? If a physician asserts a patient has hyponatremia, but there's not a single hyponatremic low sodium value at all documented in the medical record, then that's not a valid code.
Okay.
But that's a clinical validation argument. But from the coder perspective, because the physician documented the diagnosis of hyponatremia, they are obligated to code for the diagnosis of hyponatremia. So if a physician documents the code of hyponatremia, but the coder miscodes the diagnosis of hyponatremia by using some other more elaborate code for hyponatremia, then that's a coding issue because the coder miscoded the case. But what you're discussing is a clinical validation issue, not a coding issue. And this article, which a lot of insurance companies reference, is actually a coding issue, which they are trying to confuse. They're trying to muddy the waters here between two separate topics here: coding versus clinical validation. They cannot. These guidelines in AHA coding clinics cannot be used for clinical validation at all.
But they do all the time. I mean,
but they're not allowed to. That's the thing, though. Nobody argues that. Everyone feels that AHA coding clinics can be used for clinical validation, but they cannot. And they're not allowed to. And nobody points that out. And honestly, the insurance companies, after a while, they create a template that works, which scares a lot of hospitals. And since it works for them, they keep on copying and pasting it to ad nauseum to almost every single case that they distribute out.
And it's always the diagnoses that make the DRG higher severity, right? That makes it with an MCC, with a major complication or comorbidity, almost always. And then they go and they say, "Oh, here you owe me $5,000 because we overpaid you." And now we have, I love it. It's almost Orwellian, where it's like one of the insurance companies has the provider payment integrity program, right? It's very Orwellian, right? It's like, okay, we want to make sure that we cover, that we cut healthcare costs And so we're going to go and ask for $11,000 back because we don't believe obesity mattered in this case, you know?
Exactly. Honestly, if they can document it and it was present and it was actually treated, then, it counts. I mean, a patient who has severe protein calorie malnutrition with a BMI of 10 and a nutritionist consultation is saying that this patient requires protein supplements and this and that, whatever, it all counts. But just because the physician said severe protein calorie malnutrition, we'll consult nutrition, and that's what they end up documenting for the rest of the hospitalization. They figured, okay, physician is consult nutrition, who cares? The patient didn't receive the protein, the patient didn't receive any of the other nutritional substances. They kept on documenting the same way throughout. There's no effect, whatever. That's not how it works. The nutrition consultation will come in and they will provide their feedback and they'll start implement dietary changes to help the patient. The physician's not, a patient's not coming in for severe protein calorie malnutrition as their primary diagnosis. They're coming in for something more major, sepsis, or whatever else it might be. Most of them, so they're getting primarily treated. The physician's primarily concerned about treating the major life-threatening killing issues. They're not going to be wasting their time documenting out everything that the nutritionist documented in their consultation note. They're going to be like, they're just basically like, okay, we consult nutrition. They're going to do what they need to do. They're as a physician, an intensivist in the hospital, do you care about what nutrition orders they're instituting on behalf of the patient? All I care about is that the end result, that they're getting what they need and they're getting better.
Exactly. No, I mean, exactly. But it still has an impact. I mean, if they're malnourished, they're sicker. I mean, and it definitely has an impact on the whole case. It's the same thing with acute hypoxic respiratory failure. Another thing where they have all these criteria and they have to be tachypnic and they have to be distressed and they have to have this. And I'm like, where are you guys getting that from? I mean, and they just do it. Why do they keep doing it over and over and over again? I don't understand. I mean, they have to. Do they just bank on the fact that hospitals and hospital systems are just not going to fight it? Just say whatever.
Honestly, not everybody is a sound physician client, so
that's true.
And not all hospitals have proper physician advisors in them, and still, I mean, honestly, physician advisor has been around since the 1990s, but we're still in our infancy here as a field, and not a lot of hospitals have effectively adopted physician advisory programs or have a proper appeals process in place. So usually a lot of times it's just a nursing official, like the nurse case manager, whoever is managing this, and they don't know how to argue this, and a lot of times hospitals don't want to go through the argument, or they're contractually obligated to not argue it, in which case they'll just take it. And
but it seems like the return on investment is huge. I mean, if you
for the insurance companies, yeah.
Well, no, for the insurance companies, it's especially now that Medicare Advantage, the profitability for Medicare Advantage is going down majorly, right? You can see all the, a lot of insurers are really getting their stock hammered because they're losing a lot of money. I think we're going to see more and more of these clinical validation denials because it's a way that they can recoup revenue.
Honestly, it wasn't the 2 midnight rule and Medicare's rules about that. In fact, that Medicare is saying if a patient's been in the hospital for 2 midnights, the physician has documented medical necessity. Medicare's requirements for inpatient to qualify for the 2 midnight rules are very lax. There's no strict regulation there. So if a physician can prove that the patient required hospitalization greater than 2 midnights because the intensive service required it, like they're receiving IV steroids, IV fluids, IV antibiotics, supplemental oxygen when they're not on oxygen at the baseline. All these are qualifiers for inpatient stays or prolonged hospitalization. If the patient crosses 2 midnights, they qualify for inpatient status, especially if they cannot be care cannot be de-escalated or managed on an outpatient basis. So what the insurance companies want to go into is they're going to go. Right now, they are not able to overall deny a patient as inpatient appropriate and downgrade them to observation anymore because of Medicare's new further regulations and rules and their clarifications on the previous regulations and rules. Medicare is coming out and saying very specifically, you cannot patients who are in the hospital for 2 midnights or longer who have received medically necessary care and are continuing to receive medically necessary care are inpatient appropriate. End of story. So now what the insurance companies are going in to say, the Medicare is busy clamp down on the ways they can deny the inpatient stays. So now they're going through a back end saying, okay, we'll approve inpatient, but we'll deny every single code that you're going to come up with for that hospitalization.
Right,
A lot
right.
of times the payment's going to be less than observation care.
Wow, wow. Oh, yeah. So they're just trying to, okay, fine. You have inpatient. We're going to go on the back end and deny all the really important diagnoses.
And that's where we come in and with our appeals and say, no, you're wrong. How can you deny this? This was there.
Yeah, I mean, and so it's just very important for hospitals and hospital systems to not don't just take this lying down. This coding clinic, this is especially why I wanted you to come and explain to our listeners and to is why where this whole thing about the coding clinic is BS. And they have
let me just finish going through this article.
yeah, please go ahead.
Got to the point that the insurance companies keep on beating all the hospitals over the head with, basically.
Yeah.
It further goes on to say here, coders should not be disregarding physician documentation and deciding on their own based on clinical criteria, abnormal test results, etc., whether or not a condition should be coded. For example, if the physician documents sepsis and the coder assigns the code for sepsis and clinical validation review later disagrees with the physician diagnosis, this is a clinical issue, but it is not a coding error. What I said earlier, clinical validation versus coding validation. By the same token, coders shouldn't be coding sepsis in the absence of physician documentation because they believe the patient meets sepsis clinical criteria. Coders cannot come up with a diagnosis alone. They cannot create a diagnosis. All they can do is code what's in the chart. Now, this last sentence here is where things get tricky. Now, the insurance company, let me read the full sentence to you. A facility or a payer may require that a physician use a particular clinical definition or set of criteria when establishing a diagnosis. That's where the insurance companies stop. But after that word diagnosis, there's a comma, and it goes on to state, but this is a clinical issue outside the coding system. The sentence in of itself says they may create such a clinical validation criteria, but this is not at all applicable here. They put a disclaimer saying that that's something that's to be decided elsewhere, outside of us. So that sentence itself is,
it's disingenuous.
This is basically disingenuous number 2. No. The sentence itself is not disingenuous. The way the insurance companies use that half of a sentence to come up with their own absurd clinical criteria is disingenuous. What this sentence is saying that how the clinical validation, they're basically saying how clinical validation criteria are created, but it could be created when the hospital creates a coding criteria and a clinical criteria. It could be created when insurance companies create a clinical criteria, but that's a clinical validation issue. It's not a coding issue. And they are very clearly saying that is a clinical issue outside the coding system. That's a clinical issue outside of AHA coding clinics. It is not a clinical issue for coders. This AHA coding clinics guidelines, they're meant for coders, not us. But the insurance companies beat us over the head repeatedly on these issues, so we have to reference them, which is why I have the subscription here, why I've been reading through these extensively. I'm a bit of a research nerd here.
Yeah, no, absolutely. I think people should understand where that comes from. And you just see, and then there's an air of authority here, which the AHA coding clinic from 8 years ago said this, and it's only just so that everyone understands, and watching this and listening to this, it's part of a sentence. They don't quote the entire sentence, and it's a little snippet of a 2.5-page answer. And at the end of the day, what they're saying is that the job of diagnosing the patient falls on the treating physician and clinician only.
Correct.
Period. Full stop. That's it. And the insurance company has no role whatsoever.
Correct. And they have no business denying a patient's care because they don't feel that the clinical diagnosis is if they want to do clinical validation argument, they can do it, but they cannot be quoting AHA coding clinic. They have to use argue proper criteria, saying, "Oh, we don't believe it because it doesn't meet XYZ criteria." But at the same time, though, they can't come up with absurd, arcane criteria which are no longer applicable today. Another example where I've seen insurance companies use this is with KDIGO versus Aiken Rifle criteria. Aiken Rifle
Right.
criteria is the older criteria where they require a pre-hydration requirement for diagnosis of AKI. KDIGO does not do that. Honestly, one of the most common causes of acute kidney injury is dehydration and fluid losses. So, I mean,
Absolutely.
that's a pre-renal acute kidney injury. And insurance companies saying that doesn't a pre-renal acute kidney injury does not exist as an entity anymore because a patient has to fulfill Aiken rifle criteria for once they're fully rehydrated, then you can see what that creatinine level is. And that creatinine level is what was the diagnosis for acute kidney injury or not. That's absolutely absurd. That's been refuted and proven not clinically valid long before KDIGO came about,
Absolutely. So I just think at the bottom, we're running out of times, but just at the bottom line, insurance companies should never play the role of doctor. Should never. It's not their role. It's not their job. It's one thing if someone makes something up. If one thing just says, well, hypoxic respiratory failure is there even though it wasn't there. And I've seen cases like that. There's no question.
Yeah.
I've seen cases where there's absolutely no evidence of hypoxia anywhere in the record everywhere, and they just code it. And I don't understand that. That's one thing. It's another thing to allege that, oh, well, this is not important, not clinically relevant. That's not your job to do. That's the job of us, the treating physician, and just don't take it lying down.
Correct. Honestly, if it's not there, that's a clinical validation review. They can rightly point out, okay, you say the patient has acute hypoxic respiratory failure, but there's no evidence of hypoxia. In fact, the patient was intubated because of airway protection because they're having intractable seizures. The patient, as soon as the seizures abated, the patient regained consciousness, the patient was extubated. That's not acute respiratory. That's a valid clinical argument. I can't argue with that, because a lot of physicians, they assume because the patient's intubated, they have acute respiratory failure. Honestly, I have to bring up the operative, the OR. Patients undergoing general anesthesia for laparoscopic surgery, for instance, no patient can tolerate laparoscopic surgery because you're filling up their entire abdomen with carbon dioxide. You create an acute respiratory impairment, so they need to be intubated for airway protection, but that's not for acute hypoxic respiratory failure.
Well, I mean, for me,
coronary bypass surgery, they're not in acute respiratory failure.
Right. I mean, for that, I say they cannot maintain a patent airway, which is the other part of respiratory failure. It's not just hypoxia and hypercapnia, but it's also maintaining a patent airway. But you know what? I think this calls for another podcast episode where we go into the intricacies of some diagnoses to help clinicians in their coding and documentation. So we'll definitely have you back, Dr. Tirmal. Thank you so much, man, for coming and joining us and educating us about this thing. And we'll see you soon again. Thanks so much.
I'll be happy to come back.
Absolutely. Thanks a lot.
All right, bye.
Thank you for watching. Sign up at healthcaremusings.com to get every episode delivered directly to your email. And please don't forget to leave a 5-star review. Thank you so much.